10th anniversary of KDSG annual conferences, and I am more than honored to be presenting on one of the novel therapies as far as the management of obesity. A molecule whose cousins, brothers and sisters, semaglutide, has been in the market for some time, licensed first 2017-2018, but now we have an oral version which is currently available in Kenya, coming in for the first time and by a local manufacturer, so we are very proud of that as far as that is concerned. Now, obesity, I think we are catching on late as the low and middle income countries. The developed world rather, got shocked a while back, and they've been managing it in the doctors' offices. In Africa, we had handed it over to different people to look at it other than the doctors, other than our clinical dietitians, other than the sleep experts, other than the fitness experts. But now is when we are truly having these conversations, and even later in the year, I know we'll be having an obesity conference to discuss more around this. So a month ago, the World Obesity Day was observed, and the president of the World Obesity Federation said a very sobering statement. While it is clear that obesity is on the rise, and equally clear that it is equally clear that many countries are unprepared to deal with what is an increasingly serious problem for populations. What does this mean? Yesterday we had the PS Medical Services talking about policies, familiarizing ourselves. Our policies as a country, is this factored in? Because I'll shortly share the statistics, which are very, very scary, and we all need to be aware. When a patient comes to triage for the nurses in the room, and you do your weight and height, you write there the BMI and forward to the doctor, does it occur to you that beyond seeing the physician, they need to see an expert to address that particular problem? So it is something that we need to be very aware of, and this session will highlight the current definitions of obesity. Many of us are still stuck in the traditional way of, you have a high BMI, you're obese, you need to run. You need to watch your nutrition and so on. And a challenge also to the panel that was up here. When we are used, because you've done half of my presentation and my work will be very easy, because all those are non-injectable methods. When you are discussing with those patients about the options they have as far as tackling their issue of overweight or obesity, are you also managing expectations? Because it is not finite in terms of what exercise can achieve. It is not finite in terms of, it is finite actually in terms of what exercise can achieve, what nutrition can achieve, what proper sleep practices can achieve. And we need to start having the discussions about at what point does a patient need actual medical assistance as far as pharmacotherapy and surgical options. So, nobody argues with the stats, so if you want to convince the world, you produce your data. And currently, what we are seeing is that the estimates as of 2030, I know 20 years ago, 2030 sounded so visionary and so far. That's 4.5 years out, so we are already there. It is estimated that up to 1.13 billion people are going to be in that obesity 2 and 3 weight class. How many people are in the world? Those ones who know the number of the world population. Do your math, 1.13 billion, that's almost everybody. So we need to start looking at this thing with a lot more interest. In that category, those who will have a BMI of above 35 kgs per meter squared. Why 35? Because that is the current threshold that we need to observe as far as dedicating ourselves to aggressive management as far as pharmacotherapy and surgical options. That number will be up to 385 million people, doubling from what it was in 2010. Additionally, we are now told that more people are dying from obesity-related complications. What does that mean? Obesity is basically a harbinger, meaning it's a telltale sign that in the future, there's going to be a problem. There's going to be comorbidities associated. And we are seeing more people dying from those comorbidities compared to those who are dying in road traffic accidents. Think about that. Now, when we look at disease-adjusted life years, every time a patient has a chronic disease and this disease is affecting their quality of life, affecting their productivity in society, bearing heavily on the healthcare economy, you look at what those number of years spent in an productivity, cost, and it is estimated that it will rise to about 55% of the adult years living with ill health due to type 2 diabetes attributable to obesity as an NCD. Risk factors, we have heard about this from most of the speakers this morning: a sedentary lifestyle, overnutrition, which is actually cultural. In Africa, we overfeed our children, not knowing that obese children will make obese adults and so on. We need to look at that. For example, let me use an example that is day-to-day for all of us. When you're going to the supermarket to buy your cooking oil to stock in your house, how many people look at the label? How many calories are there in a serving of that oil? What's the quantity of saturated fats? Or do you just buy because your favorite is Sungold or Elianto or whichever? Very few people look at that. And because we don't look at it, we don't put our regulatory organizations to task to say, this is too high as far as calorie content, this is too high as far as saturated fats, which would then predispose to some of this adiposity and the consequences of it. So we really need to start thinking about it in that 360 level, as opposed to just being silent prescribers in our offices. Health consequences, multi-organ, in terms of mental health, which Merin has very well spent time talking about. Malignancies are now directly associated with this. Cardiovascular issues, including atherosclerotic cardiovascular disease risk, hypertension, and so on. Metabolic consequences, of which type 2 diabetes is a big elephant as far as that is concerned. Muscle D, issues with being prothrombotic, skin, name it. Any system you can think of, obesity has been associated with either aggravation or a risk as far as developing that. So pathophysiology is very complex when it comes to obesity. Pathogenetic mechanisms keep being modified as the days go by because of the interest that is currently there as far as this. So I'll summarize it as this, and Dr. Dindi did half the part. Energy intake versus energy expenditure difference. If you have a positive balance in terms of what is coming in and what is getting out, highly likely you will end up retaining, similar to what we do with our fluid charts in the wards. Right? So when you look at it from an energy perspective, physiologically, and you've seen I've highlighted at least 4 mechanisms to simplify this discussion, because if we start talking about the pathogenesis, we can spend the whole of the 20 minutes I've been given. So enteric sensory motor processes, peripheral hormonal signaling, and the peripheral and central neurologic pathways. Why is that important? Particularly for the endos in the room, because most of the therapies that are coming up are going to be centered mostly around this, and it is something that we all need to be aware of. So I'd encourage all of us to spend some time looking at the current pathogenetic postulations that are there. Has the definition evolved? This is traditionally what we would say. You're either underweight when you're below 18.5, extremely obese when you're above 35. That has now changed. Changed because as practitioners, we need precision. So you're overweight, what does that mean? So what do I do? Do I tell you to run? Do I send you to Betty? Do I send you to Marine? Where do I send you? We need clinically precise definitions to be able to guide management. And because of this, there are certain working groups working very closely with the World Obesity Federation that have defined it for us, so that as soon as that client comes in from triage, you are able to know what is the best thing I can recommend for this particular client. So BMI only doesn't cut it. You need to estimate adiposity through estimations of body size. And as Africa, because of our limitation in terms of access and financial resources, we have been given those very simple ways in terms of estimation. They cost almost nothing, but the consequence of the data it gives us is very impactful. So waist to hip ratio, the cutoffs are there. I've put an asterisk because this data is mostly based on Caucasian and Asian populations, and we hope to, from Betty and team, start getting a lot of local data to be able to contextualize this. Maybe these are not our cutoffs, but I know in the next few years, even as Dr. Mithi has encouraged, we are going to start seeing a lot of local data coming out to be able to inform some of our protocols in hospital. For the more advanced settings, even DEXA scans are available for purposes of this estimation. In addition to that, for clinical definition, you have to establish the risk or ongoing comorbidity for you to be able to say, I'll put this patient on semaglutide, this one I can do phentermine, this one I can do the other. So this was the traditional way of defining, of course, extreme obese at a BMI above 40, and the risk calculation based on disease risk. That has changed. The new definitions, preclinical, clinical obesity. The minute you classify your patient as clinical obesity, you need to start discussing medical assistance where possible. There is still room for lifestyle, nutrition, exercise, but to a certain extent. And that is a conversation that we need to start openly having with our patients. So what is preclinical and what is clinical obesity? When we look at preclinical obesity, that is basically a patient in that overweight class, but has no evidence of reduced organ tissue function and is able to manage their day-to-day activities. So that is somebody who will benefit from the advice that we've been given by all our panelists this morning. Immediately your client reaches clinical obesity defined as a chronic disease due to obesity and characterized by comorbidities, then we need to start having discussions about how to handle it the medical way. Remember, things have evolved, even definitions of certain chronic illnesses like asthma. Now we have obesity, asthma as a class of its own with very specific management and so on. So approach, the first two, of course, covered this morning. Today, I want to focus on pharmacotherapy and particularly the new options available around. For the endoscopic and surgical procedures, I think we will invite our bariatric surgeons in the upcoming obesity conference. So what is the past and the future as far as pharmacotherapy is concerned? So key developments as far as obesity treatment, nothing new. The world has been at it for almost 100 years. Started with very toxic molecules in 1933, 3-4 years later dropped because of adverse events, including mortalities. So where are we now? Fast forward, we are in 2025 using more advanced molecules, safer for our patients. Of course, not without a bit of give and take because of certain side effects, which most patients may tolerate, others may not, but at least we're in the era of GLP-1 arrays, twin cretins, and even the upcoming triple combinations that will be able to see post-marketing data on how well our patients are doing on that. So the GLP-1 arrays, this was covered in a presentation yesterday, so I won't spend so much time on it. Basically, the GLP-1 is an incretin hormone, mainly secreted by the L cells of your pancreas, and their main mode of action being stimulation of insulin secretion and inhibition of glucagon secretion based on blood glucose levels, currently used in the management of diabetes and obesity. The benefits of your GLP-1 arrays are many, but for purposes of this discussion, we will look at their effects, particularly in terms of obesity, where they will reduce gastric motility in the stomach, reduce gastric emptying, and then act on the appetite and satiety centers of the brain. Additionally, we always say beyond weight loss, the same way in diabetes, we say beyond sugar control, what else are you bringing? So the same way beyond that, they have the benefit in terms of cardiovascular risk, renal risk, respiratory system, and so on. So semaglutide, which is one of the anchor GLP-1 arrays available, for long has been the injectable form. Now, injectable and also quite high, divided into 14 milligrams of sema or a placebo. Why 14 milligrams is important to note? The very initial trials dosed it at very high, about 50 milligrams. And you can imagine with a subcutaneous injection, you're using anywhere from 0.5 to about 2.4 on the high, depending on what your targets are. So 50 milligrams, you can imagine the kind of adverse effects that the people who participated in phase 1, efficacy, phase 2, tolerability trials went through. So the honors were on the researchers to see at what best maximum dose can we balance between risk and benefit as far as side effects, but also confer the benefit of weight loss. So 14 milligrams was found to be effective with a 14% reduction of major adverse cardiovascular events. Which cardiovascular events have mostly been studied? Additional trials after that, the SUSTAIN trial and the PIONEER trials, aggregated data. So for the SUSTAIN trials, for those who are not familiar with it, it mostly looked at the injectable semaglutide, the PIONEER trial looking at the oral formulation and comparing the two and seeing what is the effect. So if you can see that graph, the hazard ratio above 1 means you're not a very good molecule because the incidence of adverse events is likely to be high. Hazard ratio below 1 basically means the risk of having whatever endpoint you're looking at as far as adverse events is better. So you can see that it favored semaglutide heavily, and also as far as glycemic efficacy, semaglutide was favored. Now, this will be coming to most of our centers and offices in the next few months because it is now available. How do you initiate? How do you transition your patient from the injectable to the non-injectable? So for those treatment-naive patients, and we've already looked at who would benefit from this, if lifestyle, nutrition, and everything else does not seem to be working well, remember to still maintain those lifestyle interventions and do this in combination. Initiate at 3 milligrams once daily, increase to 7 after about a month of treatment, and then increase again if you need to, up to about 14 after another 30 days. If your patient received the last SEMA injection last week, then you need to break it for about a week, before you give the dose. Because remember, the other injectable is a weekly injection. So you'll just give it the same duration before then you initiate your orals. This slide is basically just propping the benefits for the patients who fear injections. Cost is an issue. They have no refrigerators. So our colleagues who work in settings where patients don't necessarily have those services of fridges and whatnot will also benefit heavily from this. The elephant in the room, bioavailability concerns. The snack technology has taken care of that. I think I'm normally very passionate about this because I was in research and development of vaccines for a long time, so I know that manufacturers really listen to the input of the doctors. And because of the concerns raised with gastric breakdown, oligomerization, and so on, the snack technology, which is actually used for other molecules, it is not new, has been used to encase the oral semaglutide molecule to take care of neutralization of the gastric acid pH, prevent that oligomerization, which definitely creates a problem as far as absorption of the drug, and makes the intestinal membrane more permeable so that you can get enough of this molecule getting into the system to confer the benefits. Contraindications are the same as what we've always known: pancreatitis, people with gallstones, people with the MEN syndromes, particularly 2A, 2B, or familial predisposition to things like medullary thyroid cancer. Remember, we already looked at some of the consequences that can be associated with the same. So I'd also like to applaud the team that's bringing this molecule to the country, because over and above introducing a new molecule, they've carried out local studies whose data will be presented towards the end of this month. I'm sure we are all excited to see what physicians in their offices are experiencing as far as the patient experience, physician experience when using this oral semaglutide. So we'll be looking out for that and are eager to hear. And also we are encouraging a lot of local data and research around this so that we can inform our own policies. So other FDA-approved anti-obesity medications, there are many. For short-term use, all these for long-term use, things like Olistat that have stood the test of time. Why preference of this versus the other? It's because of that percentage weight drop that you expect. Because currently, particularly with the global crisis, you want to achieve as high a benefit as you can, because your patient, to be fair, is tolerating certain inconveniences as far as side effects while taking this medication. So even in choosing the molecule, kindly check what is the estimated body weight drop that I expect vis-a-vis the side effects of the medication. This slide, don't worry about it. It looks like that intentionally. This is to say there's a lot emerging as far as the anti-obesity medication space, including vaccines, including twin cretins that we are going to hear about later in the day, and many, many more. So we are eager to see, but the take-home message is that we have a lot of recent advancements. Please, when you find these patients, be able to classify. Is this preclinical? I can go conservative. Is this clinical? Because every time the body cells are under that toxic state in terms of the obesity and its consequences. We're losing time, and we need to advise our patients accordingly based on what their bodies can tolerate. So that's it from me. Thank you very much.